Millions of families that have never accessed the internet or used a landline telephone or even the postal service have now begun using mobile phones. And this is a dramatic opportunity to reimagine the way that we deliver healthcare. Take a typical district hospital in a low-income country. You might have 1 to 3 dozen nurses, 2 or 3 doctors, trying to provide care for a number of people that would fill 2 or 3 football stadiums. Now, fortunately, there are more nurses at local clinics throughout that catchment area, but still, some of the villages could be dozens of miles away from the nearest local clinic. And that's why the community-based health worker is on the front lines of global health. They're going door to door, often on foot or by bicycle. Now, once you have this basic infrastructure for delivering health services, the next important question is, how do we organize it and deliver it better? For example, essential medicines, life-saving medicines that we have at the hospital, do they always flow all the way down to the community-based health worker, or do we have frequent stockouts? And does this frontline health worker receive meaningful supportive supervision from the nurse or the hospital? These are problems that we can start to deal with by using computers and mobile phones to communicate. Now, I pursue this work drawing on 2 different traditions. On the one hand, I'm a designer, and my work is about innovation. And on the other, I'm a global health activist striving for social justice. And these 2 traditions used to be worlds apart. I mean, you think of the designer in the designer glasses and the black turtleneck, and you think of the activist with dreadlocks holding a sign and boycotting something. But these 2 worlds are drawing closer together every day. At least that's my goal. And one of the most important and interesting ways is that they're learning from ethnographers about how to put people first. Now, for designers, this is about human-centered insights. And for activists, this is about solidarity. And in both cases, what it actually means is spending time in the company of the people who we want to work with. Now, I want to start explaining this with an example of the opposite of what it's supposed to look like. I mean, you've all been in that situation where you've downloaded some software and you're about ready to go, and then up pops the software license agreement, and you have to click agree or continue before you can get to this resource you want, right? Now, what do? Read the fine print? Nope, because it's bullshit, right? And you know it, and they know it. You just want to get to this resource, and it's bullshit because you know that even if you had a really good reason, you wouldn't have any opportunity to change this license agreement. And unfortunately, this is how a lot of international development still works. People who have resources dangle them in front of a community that is poor or marginalized. And if that community has a sense that their voice isn't going to be heard, that they won't have opportunities to meaningfully change the way that resource is delivered, they'll just click yes. So there's this trap that you can pretend to consult people, or maybe really even try to ask them, but totally fail to understand them. And I know this is a trap because I've fallen into it myself. During my first year working in Malawi, I was working on a program to improve the supply of life-saving medicines to community-based health workers. And we had implemented this project, it seemed successfully, in 2 districts in the central region. And we were getting ready to implement in a southern district, which I had not visited before. And so I did a survey of all the healthcare workers there. Out of these 2 mobile phone networks in Malawi, which one has better reception? And the survey results came back. We bought the SIM cards. And on the day of training, I was very frustrated and really quite surprised to find that there was no network signal for the network that 8 out of 10 of these healthcare workers had chosen. And I said, you know, why is this? Why did you choose this network if it has such poor reception? It costs the same for airtime with either network. And what they told me is it wasn't a cost issue, and it wasn't a reception issue, that like I had assumed. It was actually a cash-on-hand issue. You see, in addition to the hospital work, they were going to use these mobile phones for personal use. And the network that had very poor reception sold the airtime in increments of 25 Malawi kwacha. And the network which had much better reception, the smallest increment was 50 kwacha. Now, that difference was the difference between the cash they'd have on hand, the amount of cash they'd typically have in their pocket, And so that was the barrier to access for them, is how much cash am I going to have in my pocket that I can freely spend on any given time I want to make a call. And so for me, I mean, 25 Malawi kwacha is less than $1 US, and I was asking them to take responsibility for $100 phones. It was a humbling experience, and the key thing I learned was that even though I had asked them with good intentions, I had failed to understand their point of view. And I think the reason I failed to understand is because I hadn't spent enough time in their company. These kind of miscommunication, it happens a lot because we all have more knowledge inside our heads than we can actually access at any given time. This is a big part of my research as a Gates-Cambridge scholar, and so I want to illustrate it with a thought experiment. If you stood up right now, think of all the places you could go. I mean, the literal physical locations you could find your way to from here without consulting anyone or looking at a map. There are probably a lot, right? But think about how many of those places you could write a detailed list of directions for the person sitting next to you. Would you be able to remember the landmarks, the street names, every single turn, the distance between turns? Maybe for some routes, but probably not all of them. Now think of the times that you've been on a route somewhere and all of a sudden you realize that you must have taken a wrong turn. The surroundings are unfamiliar. And you didn't realize it, you didn't remember the turn when you were supposed to take it, but as soon as you're somewhere new that's unfamiliar, it jogs your memory. So that's what happens, is that we have all these memories that are in our brains, but we can't get them out and access or articulate them until we're in the appropriate context and something jogs our memory. And this is exactly what's happening when you are at a hospital and you ask patients after they have already arrived at the hospital about barriers to access to care. Now, you may be able to look at a map with them and they can point to their village and you can see how far it is. You can ask if they arrived by foot or on the back of a donkey. But you'll get a very different picture if you accompany them from the village to the hospital. You might see that they have to walk across a rickety handmade bridge. And that bridge might have worked for the sole person walking alone, but if someone's being transported in an ox cart, it could be an impassable barrier. A related problem is that people do raise the important issues, but we don't have the same background knowledge, so we have no idea what they're talking about. I hear all the time that, getting to the hospital is hard because the roads are bad, but until you've actually been on those roads, you might not have any idea how dramatically bad roads can be. Same with travel during the rainy season. Like, until you've been in a rainy season, in a place that just isn't prepared to deal with that much rain, you don't know what kind of barrier it could be. But people are such ingenious problem solvers that if you go to where they live and work, you'll find all these ways that they've adapted to their constraints that they experience day in and day out. And sometimes they've adapted so well that they won't even think to mention that constraint as if it were a problem, because it's a problem they've dealt with. This picture is from an elementary school in rural Kenya, and the staff there had taken recycled paper and stapled it together into pouches and fixed the pouches to the window, and they put their phones inside. And I said, why were the phones in pouches? And they said, well, this is the only place that gets mobile phone reception. So we put our pouches there and we can hear them ring, and we run over and we answer the call. Now when you see something like that, I mean, if I asked these people in a survey, they'd say, oh yeah, I use a mobile phone. I get reception. But when you're actually there, you experience it the way they do. It's a very tenuous, occasional sort of connectivity. This is another workaround from a project I was on in Ethiopia. It's a rural health post with 2 extension workers, and they had created this paper dial where each slice of the pie has the name of a community in their catchment area, and each arm has the name of one of the healthcare workers. And essentially, if they were going to be out for the day, they'd put their dial into the location where they were going to be. So if someone arrived with an emergency and they needed to find the extension worker, they could send someone running to the appropriate village and go get them. Now, we had started this project with the idea that we would be putting computers in these health posts. And we get there, and I see this workaround, and I go, so they spend like the whole day away from the health post, don't they? This isn't going to be a very secure place to actually put computers. So rather than relying on reports full of numbers or experts from Washington, D.C., or Geneva, or even here in the hallowed halls of Cambridge, we do in-depth interviews with the people who are experiencing whatever place we want to work in. And so in this particular photo, I'm with Diana Kane, who now leads the design efforts at Medic Mobile. And we're interviewing a community-based health worker, and we're doing it at her home underneath the cashew tree in her backyard. Now, this idea that we should be with the people on their turf and their terms is something that has resonated in the global health community for a long time. What we can learn from designers and ethnographers is that choosing this place for this interview is likely to evoke different ideas and different comments than we would get if we took this same community health worker to the hospital and asked her questions there. Of course, you don't just do interviews, get people's point of view, and then go back and make things. The idea is for the whole process to be participatory. And for me, this started as a global health activist. A lot of us are very dissatisfied with simple trade-offs. You know, we've been told that you have to choose between preventing HIV and treating people who have HIV. And we've been told that you have to choose between treating people with drug-resistant tuberculosis or drug-susceptible tuberculosis. But these are false choices. And what we really need are to create better options, better alternatives. Now, this can just be something that we sort of express some moral outrage about, but design thinking is an approach that we can really deal with in a pragmatic way. So one of the ideas, part of the design thinking process, is to brainstorm a very large and diverse pool of ideas. And you want to put those ideas on paper, often with sticky notes. And the way to facilitate that is to get more diverse groups of people involved in your brainstorming process. The more and more diverse ideas you're evaluating, the more likely you are to get past unnecessary trade-offs and find something that's genuinely a win-win. Now, a lot of the people we work with have never touched computers before. So if we want to actually get their insights, we have to start by putting computers in their hands. It's a learning by doing approach, and it often does lead to behavioral insights. But what I'd also like to highlight today is that approaching our work in this participatory way is also very clearly empowering for these healthcare workers. It's their first time learning to use a computer, and we're making it very clear to them how valuable their insights are, because they're the experts on this community where we're going to work together. Now, one of the central parts of any design thinking process is prototyping. And this is how it works. I'm talking with someone about decentralizing care for HIV-positive people in South Africa. We're talking for a long time. It's great. I think we're totally on the same page. I'm saying, yeah. And then I draw a sketch of what I think he's told me about their healthcare system, and I hold it up and I say like this, and he laughs and he's, oh, you got the order all wrong, right? The lesson here is not that I'm horrible at conversing. At least I think that's not the lesson, because this happens with all kinds of people all the time. The lesson is that when you represent what you're trying to do in a tangible medium, whether it's a model of a product that they can touch and feel, or it's a sketch that represents a complex workflow, this tangible medium will often jog memories or evoke opinions or preferences that simply couldn't come to light when we were only using words. Now, not everyone is as comfortable as me in producing sketches that are highly functional and terribly ugly. So Diana Kane, who I mentioned previously, created a deck of flashcards. Each card has one of the common people, places, or things that we use in our mobile health programs. And so you can just put them on the deck. This is a project in Liberia, and everybody can mix and match and use them the way they want. Now, it's important to understand that a lot of the insights we really need are only accessible when we start being treated like team members. This is something ethnographers have known for decades, and it's really catching on in the design thinking world and becoming a bigger part of the global health community as well. I want to explain this with a story. Deus is a frontline health worker near St. Gabriel's Hospital in Malawi. It's a hospital where I spent a lot of time. And so we got to know each other well. We'd go fishing. I met his kids and his wife. But now we're back in his house. We're talking shop. And he lays out all his medical papers on the desk. And he says, Isaac, I film many reports. Can you fit this on a mobile? And I'd been asked that question before, but when it's Deus, my friend, asking, I felt differently about the burden of asking someone to punch data into the keypad of a phone all day. And I think that humility comes from a place of affection. And it's a kind of affection that we can only develop when we're spending time in the company of someone. And it's that sort of affection on which solidarity is built. Too often activists talk about solidarity as if it's something that we can just turn on at will. And I think activists can learn a lot from ethnographers and from designers about the concrete actions, the approach to spending time in the company of people and trying to see things through their eyes in a way that will actually build solidarity. And I do think this is a two-way street. So I'd like to suggest that there's something that designers can also learn from activists. And that's that moral imagination, or solidarity itself, has some creative value. I'm talking about what Paul Farmer calls moral imagination and what Martin Luther King called the fierce urgency of now. When you're working in a challenging setting, there's got to be something to drive you to keep saying, there has got to be a better way, and to keep looking for that better way. And I think it's when that fierce urgency sticks to the core of who we are that we can begin to understand what to do with all of our human-centered insights and maybe understand why we innovate. Thank you.